Okay, go ahead.
Hello and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator, and I'm joined today by Dr. Ben Thrower, who's going to attempt to answer as many of your questions as possible within the next hour. I'm delighted to introduce him. Dr. Thrower is the Medical Director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta, and he previously served as the Medical Director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the Senior Medical Advisor for the Multiple Sclerosis Foundation and enjoys contributing to their quarterly Focus magazine. Dr. Thrower, we're thrilled to have you. Once I give everybody a few directions, we're going to go ahead and start taking questions. So if you've never been part of this Zoom webinar with us, if you have a question or a comment, you can just put it into the app at the bottom. There's an area for Q&A and there's an area also for chat. You can do either one, but I prefer it in Q&A if possible. Also, if you are on a phone, all you have to do is press *9 if you'd like to actually ask your question live, or if you are on our web right now, you can go ahead and just raise your hand in the app down below. So, and then I'll just unmute you and you can ask your question. So there you go. We can go ahead and start. Let's see. We have one already. Saying hello. Hi, Dr. Chaffetz. I do have a couple that came in on the web, so let me go ahead and ask you. Okay, so this one says, can you talk about any promising clinical trials and when we may see results?
So lots of stuff going on in the MS world. I think probably the closest thing on the horizon would be a class of drugs called BTK inhibitors. These are oral medications. There are several of them in late phase testing, and so hopefully we will see FDA approval of one of these in the near future. I think what's exciting about this class of drugs is that they may address a level of inflammation, something called smoldering inflammation, that perhaps none of our existing therapies do. These medications are being tested across the spectrum of multiple sclerosis, so relapsing forms of MS, primary progressive MS, secondary progressive MS. So I think that's exciting. Lots of ongoing work in neural repair, which is a topic we'll take on next month with our monthly seminar. So I would say those are some of the bigger areas right now.
Thank you. Also, we got another one that wants to know, other than general recommendations, apart from eating healthy or natural foods, do you have any recommendations such as Mediterranean diet or anything else that's healthy for MS or better than most for MS in terms of diets?
So diet's always been a hot topic in MS, and I'll say the honest answer is we don't know that there is a specific diet. So there is some evidence that some diets may be anti-inflammatory. There is evidence that the Mediterranean diet, for instance, it does appear to be anti-inflammatory. And one of the ways that these are measured is by looking at some of the chemical messengers that our immune system uses, called cytokines. So what they'll do with these studies is have someone follow one of these diets and see if these inflammatory cytokines go down. So we've seen some evidence for the Mediterranean diet. There is some evidence for intermittent fasting. There is evidence for the kind of a modified paleo diet, such as you might see in the Walls protocol. I think when you think about dietary manipulations, I think it's important to think about things that are sustainable, that you could really do for the rest of your life as a healthy lifestyle modification. So I probably, push people more towards the Mediterranean diet than anything else, just because I think it's something that you could do for the rest of your life, and probably has other health benefits in terms of lowered risk of heart attack and stroke.
Thank you. This person is asking about long COVID, and we haven't talked about that recently too much, but she said, is having long COVID with MS, does it take longer to fully recover, because they have flares, right? She has long haul COVID. and she has obviously some flares that happen. She says, does long haul COVID affect recovery time?
So I think it's a difficult question because when you look at viral infections in general with multiple sclerosis, we know that any viral infection has the potential to cause a pseudo or a false exacerbation. So you could see your fatigue worsen, you could see your gait worsen, you could see your cognition worsen with any viral infection. And now you throw the COVID question into that, and the potential for long haul COVID gets a little difficult, because some of the things that people are reporting with long haul COVID, like worsened energy levels or worsened cognition over time, kind of blend in with some of these potential MS symptoms. I do think that there is the potential for, because a person with MS might already have lower neural reserve, they've already had, if you will, an injury to the central nervous system, they might be more prone to some of these longer term COVID symptoms, I think, especially in the fatigue and cognition realm.
Okay. And what have you heard about sub-Q version of Ocrevus being
Yeah.
available in the US?
So it is likely going to get FDA approval in September. So the studies with subcutaneous Ocrevus, it would still be given on every 6 month, perhaps every 5 month basis. So the dosing schedule is the same. At the full dose, it would be 23 milliliters of Ocrevus with a little subcutaneous butterfly needle put under the skin of the abdomen. It could be administered fairly quickly, over 10 minutes, and then probably an observation period of 30 minutes or so afterwards. Rather than the usual IV pre-medications, you would have all of your pre-medications, your Tylenol, your Pepcid, your steroids given by mouth. The main advantage of this is going to be just the faster infusion time. So get you in and out of the doctor's office or the infusion center more quickly. We don't have any evidence to suggest it would be any more or less effective than the usual IV form of Ocrevus. But yeah, we know people don't want to spend all their hours and hours in the infusion chair. So that's the main advantage. So it should be up and running in September, October, that time frame.
Thank you. This was a little, it was a very general question that I wrote her back and asked for her to sort of, make it a little more direct, but it is something important, and you might be able to touch on it a bit. She's talking about anxiety and how does one plan for the future given the uncertainty about the disease progression, but planning for the worst is too much and not doing anything at all is short-sighted, she said. So do you have any opinions on that?
That's a great question. And I think because MS is unpredictable, it does create anxiety for people. I think as humans, we deal much better with the known than the unknown. And so really having an honest discussion, I think, with your healthcare team about, so for me individually, if you're a person living with MS, what does your healthcare team think your prognosis is? That prognosis in general for people with MS has gotten much better these days. We have a much larger, toolbox to work from in terms of significantly slowing, if not outright stopping, any future disease progression. I feel pretty optimistic these days in newly diagnosed individuals about the potential for really, drawing a line in the sand and not seeing their MS progress over their lifetime. So I think really sitting down and having a discussion with your team about what the expectations are, and then have that discussion. What if my MS got worse? What are the things that I can do? Because I work at a rehabilitation hospital, one of the mantras that we have here is, prepare for the worst and hope for the best. So we want to have game plans in place. What if you did have walking issues? What are we going to do about that? So I would just really have a great discussion with your healthcare team. If you are dealing with more anxiety than is normal, and that's a hard line in the sand, but if anxiety is really affecting a person's quality of life, there may be more than just the normal adjustment or reaction to a long-term health issue like MS. If you think that anxiety has become an actual sort of big symptom in and of itself, make sure you let your healthcare team know about that. the incidence of anxiety and depression is higher in the MS community, and it may be part of the biology of MS outside of just reacting to changing your health status.
Mm, exactly. Kathy wants to know, what can you do for neuropathy?
All kinds of things. So if you have painful neuropathy, we have all kinds of different medications that we can look at for that. I would say in general, most of the medicines we use are going to fall into one of two camps, either anticonvulsant type medicines, things like gabapentin, or antidepressant type medicines that can be used for pain management, things like duloxetine, but there are lots of different options. I would say medical cannabis falls into this camp as a potential treatment option for discomfort. If it's a fairly localized area, so let's say that it's just below your ankles, so it's a pretty small area that is uncomfortable for you, we might even look at topical options. There are topical forms of lidocaine. There are even compounded topicals that have a little bit of lidocaine, a little bit of gabapentin that can be used for neuropathy.
I have to say, in the last 10 years of my life, I have met so many people that are suffering from neuropathy that don't have MS, that don't have diabetes, that just
Yeah.
randomly have so much of it. It's blowing my mind how
So when we
often I
say,
hear of it.
yeah, it's common. And so when we say neuropathy, I mean, is it coming from the brain and spinal cord, which is what we see in MS, or is it coming from the peripheral nerves downstream, which is what you would say diabetes? If you have a peripheral neuropathy, the majority of people with that type of peripheral nerve damage who are experiencing pain, we don't know what's causing it. So even though diabetes is common, really that there are a lot of folks out there that it's just idiopathic. We don't know what's causing that nerve damage.
Hmm. We have a question saying that they've had 2 surgeries in the last 8 months, and now their walking has gotten worse. What can they do?
So again, being at a rehab hospital, I'm pretty biased towards physical therapy. So anytime we hear of a change in walking, we want to think about getting you in with a physical therapist to see if we can restore that function. And keep in mind that we want to be mindful that there could be other things contributing to walking issues outside of MS. We want to make sure we're not missing something else that could be contributing to your walking issues. But I would say the first thing that usually comes to my mind is getting people in with a physical therapist to try to get them back to their baseline.
Okay, Kenny's asking a question, and I'm going to ask him to please just tell us more about this. I don't understand the question. What to promote remyelination? I don't know if you need me to have him type
Yes,
in
I
a little
mean,
bit more.
so no, I think that's obviously that's one of the holy grails of MS care is it's a remyelination, neural repair, and ultimately what we want is to reverse disability. That's the goal of remyelination. So there is a lot of research going on. Again, that's the topic we're going to focus on in August. Why don't humans remyelinate better? Other animals seem to remyelinate much better than we do. What are the things in the human central nervous system that are blocking remyelination, and how can we potentially attack that? So right now in the MS world, everything that we do in treatment is going to either focus on treating relapses, treating symptoms, or preventing disability in the future. We hope in the near future that we have a fourth treatment avenue, and that's going to be reversing disability through remyelination.
Thank you. Monique is asking, can you please say a little about the efficacy of a drug like Opris as compared to beta interferon?
So if you look at our platform therapies, the older therapies, interferons and Copaxone, I would say that those were wonderful. And when that was all we had, they made a big difference. Now, if you look at drugs like Ocrevus, Tysabri, Briumvi, Kesimpta, Mavenclad, in general, they are more effective therapies. We don't want people who are on an older therapy, though, to think that they absolutely have to switch to a newer therapy. The goal of any of the disease modifying therapies is no relapse, no progression of disability, and no new MRI lesions. If you're on an older therapy like an interferon and you're meeting those goals and you're happy with the medication, there's nothing to say that you have to switch to something else. most MS centers now with a newly diagnosed individual with a relapsing form of MS are kind of biased towards going toward the more effective therapies like an Ocrevus or a Tysabri or Briumvi or Kesimpta, Mavenclad, those types of drugs. Just because if I took 1,000 individuals with MS and 500 are on one of the older therapies and 500 are on one of the newer therapies, the people on the newer therapies generally are going to have better control of their MS.
Thank you. And someone's asking if, because their leg muscles are very tight lately, is there anything that they can do to alleviate the muscle tightness?
Yeah, so spasticity is a big issue in MS, and it's probably an under-recognized symptom for people with MS, partly because people have a hard time describing it, what it actually feels like to them. So when we think about spasticity management, there's kind of a pyramid, if you will, and the base of the pyramid would be removing noxious stimuli. If you're having recurrent infections, UTIs, if you have a brace that's not fitted well, like an ankle foot orthotic, that irritation to the muscles in the legs can actually kind of set off spasticity. Next notch up would be real rehabilitation, stretching, and more stretching, usually with the help of a physical therapist to get us into a good stretching routine. And then the next notch up is going to be medications. Baclofen and tizanidine have been our old standbys. We sometimes look at things like dantrolene or Dantrium. This would kind of be where medical cannabis fits in. Then we get up into the little bit more esoteric things like Botox injections, intrathecal baclofen or a baclofen pump. So that's kind of the usual thought process of working our way up that pyramid of spasticity management.
Andrea, or rather our air, I don't know what her name is. It doesn't show it, but Ariana, I think maybe. I'm allergic to Rituxan and have to take steroids and very slow infusion speeds to tolerate. Is Ocrevus typically tolerated better, or will the subcutaneous infusion work any easier on the body's acceptance?
So if you're having infusion reactions to one of the B cell therapies like rituximab, the options are either we try to medicate enough, like with steroids or Benadryl, so that you tolerate it, or slow the infusion rate down, like she mentioned, or move to another option. We never know if someone's going to cross-react. I have had individuals that had issues with one B cell therapy, like a rituximab. When we move them over to the other one, they did fine with it. So if the infusion reaction is serious enough with rituximab, I think I would certainly think about one of the other B cell therapies, because you may tolerate that better.
Chad's asking, is there any way to reduce the MS hug other than gabapentin?
So the MS hug, we think, is either in the family of spasticity, so all the things we just talked about for spasticity management, or it's in the family of kind of a neuropathic pain or dysesthesia. And it's hard to know sometimes which is happening in a given individual with MS. Is it more the tightness of the muscle, or is it that abnormal sensation, just the hypersensitivity? There is some trial and error to that. So trying out something like gabapentin is certainly not a bad starting point. If that's not working out, we might try something that you would typically use for spasticity, or maybe we move to something like duloxetine. One of the challenges with gabapentin is that there's such a huge dosing range in humans. Gabapentin comes in a 100, a 300, a 400, a 600, and an 800 milligram. And the dosing range could be anywhere from 300 milligrams per day all the way up to 3,600 milligrams a day. So there's a lot of playing around with dosing with gabapentin. Normally with gabapentin, what we'll do is we will start a certain dose and we will go up on that dose until one of two things happens. Either the person is happy with the degree of symptom control, like the MS hug, or they're really starting to run into drowsiness or lightheadedness.
I'm going to ask one more question before I start taking people who have their hands raised. So this is a great question. Do you know of any centers or clinics or hospitals that offer 24/7 care just for MS patients with full PT/OT therapies to relieve a caregiver for a few weeks?
So there are two ways you could get that sort of care. If you've had an acute attack, So you've had a relapse or you've had a urinary tract infection that lands you in the hospital, you can go from an acute care hospital into a rehab setting for 2 weeks, 3 weeks of a tune-up. If you've not had an acute attack, it's very difficult to be admitted for inpatient rehabilitation if you've not had that acute attack. One of the things that we set up here at Shepherd to try to get around that challenge is we have a program, and others may have it as well. Ours is called ITP. Some people call it day program. Our ITP stands for Intensive Therapy Program or Integrated Therapy Program. This is a 3-week program where we take all of those things that you would get in an inpatient setting: PT, OT, speech language, counseling, bowel bladder management. And so you're working with this therapy team for 6 to 7 hours per day. But due to some very generous donors that we have in the Atlanta metro area, we can have the person and a significant other stay in an apartment at no charge to them for that whole 3-week block of time. So they're not driving back and forth every day. So it really has been a great sort of way to get people tuned up and give some respite to caregivers also.
Incredible. I think that's why people come from all over the world to the Shepherd Center. I've heard people
We're
travel from all over.
very, very blessed with some great
Yeah.
philanthropists here in the area.
Incredible. Karen, I do see that you have your hand up, so I'm going to allow you to talk. You can ask your question.
Okay, thank you.
Mhm.
I'm calling about Mavenclad. It's always curious to me. I'm on a B cell depleter. And so why doesn't everybody just take 2 pills now, 2 pills later, and one and done? I mean, is it something you do later in life when you've not had any? I've been on B cell for a while, no progression. Is this sort of a final chapter medication? And what's the danger of loss of your immune system with that medication?
Yeah, great question. So a lot of people do think of Mavenclad as sort of one potential use would be as an exit strategy, like you're saying. So, as we get older, there may be a point in time where an individual with MS doesn't need to be on any therapy, still an area of a lot of research. And some people look at Mavenclad as something to help get you there. So maybe you have a 55-year-old person who's been on B cell therapy for a while, and you say, well, gosh, I could do these 2 courses of Mavenclad a year apart, and then they're done. I'm going to have the Mavenclad carry them on out until their immune system hits that sort of natural point where they don't need to be on treatment. Mavenclad has a lot of appeal for the reasons you mentioned, just doing the 2 courses and then in theory you're done. I think one of the challenges is, what if you had a 25-year-old person? What do you do 20, 30 years down the line? Let's say you've done the Mavenclad and now they start having some breakthrough symptoms 20 years later. Do we redose them with Mavenclad? Do we put them on another therapy like a B cell therapy? I don't know that we have the final answer to that quite yet. So I think for those reasons, I like Mavenclad. I think it's a good drug, but I would probably tend to think of it maybe as that for a lot of our folks is that exit strategy drug to maybe get someone off of a natalizumab or B cell therapy as they get up into that 55-year-old range.
So as far as your immunity depletion, what does that?
So on paper, because Mavenclad does work by knocking down both the B and the T cells, and then when they come back, they seem to be reprogrammed into a less inflammatory state. We had some concern when Mavenclad first got FDA approval that when those B and T cells are down, are we going to see a really high risk of infections? And we've been pleasantly surprised that in the real world, we just typically aren't seeing that. I'm not sure I can completely explain why that would be. We sort of did a forced experiment, if you will, on how immunosuppressed are people on these different therapies, in the setting of an infection risk. When the Delta surge of the COVID pandemic hit, we really got to see how people did on these different therapies. Were they at higher risk for hospitalizations or deaths if they picked up a COVID infection? And we really didn't see any higher risk of hospitalizations and deaths in our Mavenclad population. The one group that we did have to be a little cautious about actually were our B cell therapy patients. There was a higher risk of hospitalization and death with Delta infections in that group. And we use a lot of B cell therapies. I think they're great therapies, but we did have to use a little more caution in that group.
Thank you. Thanks, Dr. Thrower. Thanks, Karen, for your question.
Thank you.
Okay, let's see here. Do you believe that not taking any medications can create long-term problems?
So, it probably depends upon where you're at on the MS journey. So for newly diagnosed individuals, we are biased towards getting people on treatment with relapsing forms of MS. The data has been very strong that, if you look at groups of individuals who are newly diagnosed, in general, people do better with a disease modifying therapy than without a disease modifying therapy. Now, if you're 60, 65, you're an older individual and your MS has been stable for years and years, that's a very different discussion. And there's a lot of research in, again, do we need to have that older individual on an MS therapy? And that's, there's some evidence that maybe we don't, maybe people do fine in those, above a certain age range. But in the younger groups, we're kind of biased towards getting people on treatment. There are some general guidelines to making a prognosis in a newly diagnosed individual, but they are far from perfect. I'm very nervous about telling a newly diagnosed individual, I think you're going to do absolutely fine over 10, 20, 30, 40 years, and you really don't need to be on treatment. I would probably err on the side of nudging that person towards getting on something when they're newly diagnosed.
And Judy's apparently staying up for several hours every single night. She can't fall asleep. Do you recommend anything in particular for that inability?
So sleep disruptions are unfortunately common with MS. The first question would be, is there a symptom that's interfering with sleep? Is it, spasms? Is the person having, urinary frequency that are making it difficult to maintain, sleep or get to sleep? Some people don't have any symptom. It's just a sleep issue. They can't turn their brain off at night. And that's then when we started looking at different options to help someone get to sleep. In terms of non-prescription things, we use anything from just plain old CBD with little to no THC in it. That does help some people turn their brain off at night. Melatonin, lots of over-the-counter sleep aids. Some of the over-the-counter sleep aids do have diphenhydramine or Benadryl in them. And it's not that that's a bad thing. You just need to know how you tolerate it individually. Some people with diphenhydramine, may get dry mouth or constipation. They may actually have a kind of a hangover effect into the next day with diphenhydramine. When we get into prescription drugs, we have the usual kind of suspects, things like Ambien and Lunesta, which have a role. They can be okay to use. We need to think about the potential side effects of those also. There's an old antidepressant medicine, trazodone, that it wasn't meant to be a sleep aid, but it is sedating it and it's non-addictive. We'll sometimes use that to help people get to sleep. If we just are really exhausting our options and someone's having sleep issues, we do refer people to sleep specialists to kind of get that next level of treatment options.
Thank you. And Diane's wondering, why does it seem that clinical trials are never really for older patients or people that have had MS for many years?
Yeah. So, if you're a researcher and you're sitting in a lab or someone designing clinical trials, you want to have the highest chance of success and you want the most homogeneous patient population you can get with a very low chance that there are any other health issues. So you want this perfect, group of, if you let a researcher design the trial, they're going to say, well, I want a group of 30-year-olds who have no health issues whatsoever. You're really taking out other variables. We don't like that. And so, there's always, when you look at clinical trials and who's designing the trials versus people like herself or people in the the healthcare trenches, we want it to be as broad as possible, to be as inclusive as possible. So there's always that give and take between what a pure researcher would want versus the real world. One of the challenges that we see is that sometimes clinical trials they're not inclusive, and so we don't know what a drug looks like in a 70-year-old versus a 55-year-old. There has been an underrepresentation of African Americans and other people of color in clinical trials, which has been a real problem, because there is some evidence that maybe MS is immunologically different than, say, a Black person versus a white person. So I would say we hear that. It is getting better, especially now that we're looking at neural repair trials. Some of those studies are now finally targeting people with more disability and who are the older into the age range. So it is getting better. We know it's been a problem.
Thank you. Monique says in her experience, lesions do not always reflect what patients' clients present clinically. Are we not overstating the importance of what is revealed in an MRI?
So that's a great point. And so there is not great correlation between where the lesions are at on MRI, especially brain MRI. It's a little better with spinal cord, but where the lesions are at on brain MRI has pretty poor correlation with what sort of symptoms the person is dealing with. One of the reasons for that is when you think about what a white spot is on MRI, it really is scar tissue. It's gliosis. Within that white spot, there may be restored brain function. So if that person has remyelinated to a certain degree, we can't appreciate that with standard MRI. So it's still going to show up as a white spot. Even without remyelination, we can reestablish electrical conduction across a demyelinated nerve fiber. So there can be normal function within that white spot. The converse is probably true as well. So it's been estimated that good MRI is probably only imaging 50 to maybe 70% of what's really going on in a person's brain with MS. So there's all this stuff that we're probably not seeing, things like gray matter disease, that may be contributing to the person's symptoms. So it's very different from, say, stroke or traumatic brain injury. With a stroke, you can look at the MRI and pretty well predict what the individual would look like symptomatically. That is absolutely not true with MS. We can show you individuals who have pretty ugly brain MRIs who look pretty good in real life, and vice versa.
Two comments. One, that's Monique's very pleased about your positive views on cannabis. She's glad to hear that. And Mary says that the but I think it's called Banana Sana pose in yoga stopped her hugs as long as she does it every single day. And she does it in a chair.
Wow, that's good to know. If you can do yoga, not a medicine, more power to you.
Exactly. Okay, I'm going to let Doris, I'm going to go ahead and let you talk. So you can go ahead. I've unmuted you.
Thank you very much. I wanted to check in for a moment as a relatively long-term patient now, maybe 7 years. I've been on the Rebis, currently on Ocrevus. I've heard you, Dr. Shepard, say or Dr. Thrower, I'm sure you've had that happen to you a lot, where people call you Dr. Shepard.
That's okay. I'll take that one. Yeah.
I like that too.
Yeah. But it's the place that I'm treated and I have so much interaction with. But what I was curious about, because you mentioned Mavenclad, and I thought that Mavenclad was more relapsing remitting or otherwise, that it would not be appropriate for somebody with primary progressive.
You are correct. So with primary progressive MS, the only FDA approved treatment that we have is Ocrevus. So that's a good distinction. So if we're thinking about that, using Mavenclad as sort of an exit strategy from disease modifying therapies, that's really only going to be FDA approved for someone with a relapsing form of MS. That's a great point.
Okay. Thank you very much, both of you.
Thank you.
Okay, So if one of the B cell therapies isn't working for this person, does it make sense to try another one? They're currently taking rituximab. Would it make any sense at all to try Ocrevus or Kesimpta?
So the B cell therapies ultimately all have the same mechanism of action. So in MS, all of our B cell therapies are anti-CD20 monoclonal antibodies. Slight differences in the molecules, some difference with Kesimpta that it's a monthly subcutaneous medicine. But if you are not clinically responding in the way you would like with one B cell therapy, there's not a lot of evidence that switching to another one is going to make a difference. I would say the one exception might be if for some strange reason, when we do your labs, if you're on a B cell therapy, if you are not B cell depleted, which is unusual, but if your CD19 count, which is sort of a surrogate marker for CD20, if that's not really low for some reason, you could say, well, let's see if another one would lower it. That's a really unusual situation to see, though. The most common reason that we might move between B cell therapies is either convenience. Someone likes the every 6-month IV versus a monthly sub-Q, or vice versa, or maybe if the person's having infusion reactions, we might try switching between. But usually, if it's not working the way you want it to, I don't see a lot of rationale in moving to another B cell therapy.
Thank you. Do you have any suggestions for Angela who's having night sweats that are keeping her up?
Well, that is a tough symptom, and so it may or may not be related to your MS. Some people with MS do have autonomic dysfunction. Their thermostat is off, and so we do see sometimes inappropriate sweating, especially at night. I would have your healthcare team just look at your medications. Once in a blue moon, night sweats can be a sign of a side effect of certain medications. If the person were female, just making sure that there's not any kind of hormonal fluctuation, that the person's not perimenopausal. But a lot of times it just comes back to it may be part of the MS, and it's a tough symptom. I'm not sure that we have a great answer for night sweats. There are some cooling sheets out there that make a difference for some people. But in terms of a medication or a quick fix, unfortunately, I'm not sure we have that.
I know there's a company by the name of, they make cooling devices, vests and things like that. And they also have pillows that you can
Yeah.
sleep on that have the cooling packs inside. And so you can try that also if that helps.
There was a
Okay.
neat article. So CNN, when we were having the whole nation was under this heat dome, and we're having these extremes of heat. Seems like it was about 2 weeks ago. CNN had an interesting article on cooling strategies. It wasn't MS specific, but a lot of the things they were recommending would certainly be helpful in MS. I think if you went on CNN and you just did a search on cooling strategies, you should be able to pull it up. And they had a lot of those pillows and sheets listed in there.
Thank you. Srini wants to know, are you enthusiastic about the frexalimab phase 3 trial?
So I would say, we're always optimistic about any phase 3 trial. If something's gotten to phase 3, it means it had to show some efficacy in phase 2, and it had to have at least reasonably good safety in the phase 2 study. So anytime something makes it to phase 3, I would say, yes, we are optimistic. There's always that challenge, though, that, when something goes from phase 3, now it's FDA approved and it's in the real world. I think, the person earlier made the comment about who gets into phase 3 studies. Sometimes it's you're looking at this group of people and now it gets FDA approval and I'm going to treat this group of people. We always want to keep a cautious eye out for side effects or lack of efficacy in the real world that we didn't pick up maybe in a phase 3 study.
Thanks. Sherry wants to know, for about a year, let's see, I'm about to start year 2 of Mavenclad and I'm nervous because I was sick with a sinus infection. Any thoughts?
So if you have an increase in your baseline infection rate on any drug that is potentially immunosuppressive, including Mavenclad, you'd certainly let your healthcare team know. it's not an absolute given that that sinus infection was due to the Mavenclad. Maybe it was just bad luck and you got a sinus infection just because anybody can get one. But do let your healthcare team know. They can talk to you about the risks and benefits, of going ahead with round 2 of Mavenclad. Again, I would say, in our experience here and from what we've seen in the years and years of data that's out on safety, I've been very pleasantly surprised with the low incidence of infections that we're seeing with Mavenclad.
Paul is asking, what can you tell us about swelling feet and how to deal with it?
Yeah. So swelling in the feet is a fairly common thing for people with mobility issues in MS. When you think about what gets fluid out of our feet, a lot of it is muscle contraction. So you have arterial pressure driving blood down into your feet, and what gets fluid back up is muscle contraction, and then the veins have one-way valves. Well, if you have weakness in your legs, you don't have that normal muscle contraction to get fluid out. So when I see someone with swelling in the feet, I always want to make sure there's not another medical issue, that the person doesn't have, renal disease or heart issue. Realize too, some of our medications like gabapentin can contribute to a little bit of swelling in the feet, but a lot of times it is really that lack of muscle squeeze in a person with mobility, the issues that's causing the swelling. So gravity is your friend, just like keeping your feet down the fluid's gonna pool. Most people with swelling in their feet from MS notice their feet look better in the mornings, and that's because their feet have been up. So as much as you can, keeping your feet elevated to get that fluid out. Compression stockings can be a help. We know they're a hassle. For a compression stocking to be effective, it's got to be really tight. If it's really tight, it's a pain in the butt to put on, and it may be uncomfortable, but that is an option. There are physical therapists who specialize in something called serial wrapping. Basically, you go in for a few sessions, they're going to wrap the legs really tightly with some sort of like ACE wrap. It's just squeezing all of that fluid out of the tissues. They do this for several sessions, and that may last you for weeks or longer to have decreased swelling in the legs. I'm not a huge fan of diuretics or water pills for swelling unless there's some other medical reason for that. If it's really the MS that's doing it, if it's the MS, you really are not retaining fluid. Your normal body fluid is just going where gravity is going to let it go. So it feels funny to me using a diuretic to get rid of fluid that's really not excessive.
Thank you. So this person says because they've been on rituximab for more than 2 years, their neurologist is saying that they're not going to be checked any longer, their blood work, before their infusion. So their B cells won't be checked, and they're a little concerned. So can you comment on that?
Yeah. Again, I don't want to comment on anyone else's medical care, but I don't like that idea. I mean, I don't care if you're on Mavenclad for 2 years or 20. I'm sorry, rituximab for 2 years or 20 years. We're going to do labs before every infusion. Some people do labs in between infusions. We just from a convenience standpoint, we like doing them on the day of an infusion. You come in, you see the provider, get your labs checked. They can change over time. In my experience, over time, some people become sort of sensitized to B cell therapies. So over time, what you may see is that person who had a normal lymphocyte count or a normal IgG or IgM, over time, they may start creeping downwards. And we have actually, a lot of our folks started reducing doses over time because it just doesn't seem like the person needs the same big dose that they did. There's a lot of interest now in maybe extended interval dosing B cell therapies. There is this thought that B cell therapies may work a little differently than what we thought they did. It may not require that your B cells be completely depleted. There is some evidence that as your B cells come back after a dose of something like rituximab, they may come back in a kind of a reprogrammed, less angry state. So bottom line is I don't like not checking labs in someone. I think as long as someone's on a B cell therapy, they need to have their labs checked.
Mary said I found zip compression socks on Amazon and they work perfectly.
Awesome.
So, yeah, I asked my doctor first before using them, so that's great.
What were they called? What was the name again?
Can you tell us the name of it again? Because I've already deleted it.
Oh.
I don't know if she mentioned the name. I'm sure she'll
Okay,
tell us again.
yeah.
So another question is how doctors determine whether to keep a person 65 and over on Rituxan.
Yeah, so there is no easy answer to that, and there's a lot of discussion and the research ongoing about that very issue. So de-escalation or taking people off of therapy. There was a study recently where they looked at taking people off of a B-cell therapy versus natalizumab, Tysabri versus Gilenya, and the group that seemed to have the smoothest sort of time when one of these drugs was discontinued was actually the B-cell therapy. Now they did Ocrevus, but I think the same would apply to rituximab. And this may speak to the fact that these B cells, when they're repopulating, when you stop a drug like rituximab, maybe they're coming back in a less angry state, and you can get away with not being on the therapy. That combined with just the normal calming of the human immune system with age. So I think that there are a lot of different ways to approach that. If the person's been really stable, do you just stop the rituximab, which may be perfectly fine? Do you just start spreading it out? Maybe you go from 6 months to 9 months to once a year and then off of it. So I think there are a lot of strategies for maybe coming off of that of drug like rituximab.
Thank you. And by the way, there's zipper compression subs.
Okay, thank you. Good
That's
to
what
know.
they're called. Can you please point out some neuro repair clinical trials, either now or as a follow-through?
Yeah, so there's a trial out there right now called Vista, VISTA. It's looking at a molecule. It doesn't have a name yet. It's Pipe 307. That's an add-on trial, so you would stay on your existing therapy, and then you would be randomized to adding this on to what you're on. That's an oral agent. There is a study called Caliper, CALIPER. That molecule looks like it may have some repair potential. There are a lot of small trials out there, mesenchymal stem cell studies, and those may be limited to one site. One of the best resources if you're looking for studies like this is just use clinicaltrials.gov. When you go on there, you could type in multiple sclerosis / repair or remyelination / multiple sclerosis, and it will pull up any studies that are actively recruiting, especially in your area.
Okay. Clinicaltrials.org, did you say?
.gov, G-O-V.
.gov. Okay. I just put it into the message. Okay. How about switching to Kesimpta instead of Copaxone?
So again, very different drugs, and whenever you're looking at disease modifying therapies, you can give them a scorecard. So Copaxone's pluses is safety. I don't think there'll ever be a safer drug than glutamate acetate, whether it's name brand Copaxone, Glatopa, generic glutamate acetate. Is it as effective as Kesimpta? No. So again, what it really comes back to is think about the goal of treatment. It's no relapse, no progression, no new MRI activity. If you're not getting that with whatever therapy you're on, then it's maybe time to start looking at something else. In general, Kesimpta is going to be a more effective therapy. It does come with a little bit more risk. You are depleting B cells. You're going to have labs that have to be done with Kesimpta, whereas Copaxone really is our only DMT where there's no lab testing required.
And do side effects of teriflunomide generally become less the longer one takes the DMT? What's a fair amount of time to give it?
Yeah, typically with teriflunomide, some of the side effects you're going to see are going to probably be right up front. So GI upset's one of the more common side effects. Liver function abnormalities are more common when you first start it. Usually, if you can get through 6 months of teriflunomide, you're probably past the GI upset and liver function big liver function issues. We still do the liver functions periodically. Hair thinning is something that could build up over time. You could see it being more of a problem as the person's been on teriflunomide longer. And the sneaky side effect with teriflunomide is a peripheral neuropathy. And that is something that develops over longer periods of time. So if you're on teriflunomide and you have any new numbness or tingling in the feet especially, don't just assume that it's your MS that's doing that. Make sure to let your healthcare team know, because there are occasional cases of neuropathy that pop up, and that's a deal breaker with teriflunomide. That we got to get you off the drug if you develop that.
Thank you. What's your opinion of putting a 65-year-old on Ocrevus after 30 years of MS, since having active lesions and progression?
You know, for most humans, our immune system calms down as we get older, and so it would be less likely that a 65-year-old would need to start Ocrevus versus a 35-year-old. But there are people whose immune systems just didn't read the textbook, and their immune system still thinks they are 35. So although it's unusual, we do occasionally see, people over the age of 60 who are still having new lesions form on MRI and having disease activity. And so that, just because you're 65 doesn't absolutely mean that you don't need to start a disease modifying therapy. It's not the norm, but that's sort of the definition of MS is, just when you think you've seen everything with MS, someone's going to throw some curve at you.
Right. Karen wants to know, how soon do you think the MS-specific blood tests like Octaves will become standard care? Do you use them now?
So I think we are really close to using biomarkers. So whether it's just the neurofilament light chain by itself, or whether it's part of a bigger panel like the Octave panel, we are right at the cusp of starting Octave routinely. One of the challenges that we wanted to make sure that it was going to get paid for individuals, and then there is a little bit of logistic issues with and this really is with any new thing in MS, whether it's a new MRI order, a new medication, a new lab like Octave. We live in a different world now. So with Octave, a center like Shepherd, we draw it, we do the initial processing, but Octave actually has to run it. So there's this coordination between the two labs. And now we live in the world of electronic medical records. So whenever you have a new thing that you want to do as a healthcare provider, your IT people actually have to build that into the whatever electronic medical record. And that is not always a speedy process. So, so like for us, the Octave build into the electronic medical record is actually what is taking us a minute to get up and running.
Summer says that she has primary progressive. Hi, Summer. I've been told I have walking fatigue. I take Empira. The wakeful meds do not help me. In fact, they make my legs more rigid. Anything else I can try?
So you'd want to know. So she said really two different things there. So we talked about rigidity, which would be spasticity. So that sends you kind of down one treatment pathway, versus nerve fiber fatigue. My legs are pooping out the longer I walk. So those are kind of two different things. And you may have both that you're dealing with, but your spasticity is going to be dealt with kind of through one pathway. With nerve fiber fatigue, the chances that Empira or dalfampridine, or the old school version 4-aminopyridine, the chances that that's going to help your endurance is about 40%. So, and we don't understand why, but 60% of people with MS just don't get any bang for the buck with a drug like Empira. There are other things that we can look at to improve endurance. This is where we get physical therapists involved who are very familiar with MS. There is some research out there that training with heavy weights with fewer repetitions may actually help endurance. There's some research looking at rehab strategies like something called FES bike, functional electrical stimulation bikes, where you're on a stationary bike, but you have these electrodes on the muscles that start firing the muscles for you when you fatigue. And there is good research to show that that may carry over into better endurance in your daily life.
Thank you. Great answer. When does a person switch from 7 milligrams to 14 milligrams of teriflunomide?
Yes,
How much more effective is the 14 milligrams?
The studies were done with 14. So the standard protocol is 7 milligrams for a week, and then you go to 14 after that. We do see individuals that can't tolerate the 14. They felt fine on 7, no GI upset, and then when they went to 14, they started having GI side effects. So I think 7 milligrams is still a potentially effective dose, and if it's what the person tolerates, I'm fine leaving them on 7 milligrams.
Great. Any stem cell trials that you are aware of?
There are stem cell trials going on out there. Again, I would go to that clinicaltrials.gov. There's still a lot of questions with mesenchymal stem cells. So that's one type of stem cell. Those are the more reparative stem cells. The hematopoietic stem cell transplantation, that's the bone marrow transplant procedure. There is a huge trial recruiting right now. I want to say it's called Beat MS. There are multiple sites around the country. These are all university-based MS centers, because when you do hematopoietic stem cell transplantation, you have to have a bone marrow transplant unit on site. The person's going to be in for probably 4 weeks or so after that procedure. So there is a large trial recruiting right now. I think if you go on the National MS Society website, there's a link on there for the Beat MS trial.
Thank you. And Srini's asking what the efficacy of functional electrical stimulation devices are.
So what the research has shown is that does seem to give people better endurance in the real world. This is something that would be done through physical therapy, and it's an ongoing process. So normally you're going to come in once a week, twice a week, maybe, depending upon the logistics, and work with an FES bike for 30-minute sessions, just like you would any other exercise program. And again, what the research has suggested is that does seem to equate to better endurance in the real world.
And can you repeat the question about the 7 milligrams? Oh, let's see. I've already deleted it, but do you remember?
Yeah, so it was, what was the efficacy of 7 milligrams, or when do you switch from 7 to 14? So again, the standard switch time is after a week. So 1 week of 7 milligrams teriflunomide, then go to 14 milligrams of teriflunomide. But again, that's very individual. That's the way the original phase 3 study was done. But we do have some people that we leave on 7 milligrams indefinitely if that's what they tolerate.
Yeah, thank you. Took Copaxone for 25 years, thought that they were progressing with MS, so went off of it for 8 months. The MRI showed 2 new cervical spine lesions. Not a good idea to go back on Copaxone since MRIs did not show new activity previously. That's a question.
So you could say if you were stable on Copaxone, or stable-ish, I mean, it seems like it was doing something. So now I think the argument now, or the question now, is do you go back on Copaxone, or do you up your game? Do you move to something that might be more efficacious? I don't think there's a right or wrong answer to that. Some of that comes down to individual risk tolerance. I think a lot of MS centers are biased towards liking more efficacious drugs. I mean, Copaxone's been a great drug for a lot of people over many, many years. My bias now, if I'm starting something or switching to something, I'm probably going to look at something that's more effective, like a natalizumab, a B-cell therapy, a Mavenclad.
Thank you. Christine says when it's hot, she sweats nonstop, but when it's cold, her legs don't want to work. So is there anything she could take? Because this really causes family issues. She can't go out because, they're in the Midwest. She wouldn't be able to go out with her family.
Yeah. So we talk a lot about heat sensitivity in MS, which about 70% of people with MS have, but we don't talk as much about cold sensitivity. And it's very real. And what tends to happen in most people when they get cold is exactly what she's describing. Her spasticity is acting up. Her legs stiffen up, and she kind of becomes the Frankenstein walk at that point. So we could try being more aggressive with spasticity management, especially in the colder months. So I think that would be one strategy, or we can try really just keeping her from getting chilled, and just being as super, warm as you can. Obviously, if you live somewhere in the Midwest and you get sub-zero temperatures, it's a little more challenging. I would just look at anything out there that helps you keep you warm. The thermal underclothing there's out there. Invest in as good of a parka as you can, that's going to keep your core. Really, it comes down to your core temperature. So even though your extremities might feel cold, like your hands or your feet, that's probably not what's worsening your spasticity. It's probably the drop in your core temperature. So anything that you can do to keep that core warmer hopefully prevents you from stiffening up.
Okay, that's wonderful. I love you, Dr. Thrower. Your answers are wonderful. So we are at the end of our time, and I really appreciate, honestly, all of you people that have been writing in these terrific, wonderful, sweet thank yous to both Dr. Thrower and myself. The foundation loves having Dr. Thrower. We love that he comes every other month and does this, and on the opposite months, he will actually bring up a topic and speak about that. You're welcome to join us for those also. But it's very sweet of you to all be thanking us and thanking us. We love our job. So anyway, so that is at the end. And so you know what, as far as Chad, we are going to be, this is recorded, so you'll be able to see it on our YouTube channel. So I'll mention that in just a second. So and Dr. Thrower, unless you have something else to say, I'm going to say,
No,
bid us adieu.
I would echo what you just said. Thank you to you, Deborah, and to everyone who's behind the scenes at MS Focus for all the work, and to all the folks that join in. We are honored and humbled to be a part of the MS community, and we do love what we do.
We do, and I thank everyone for coming over and over again. We see the same faces and the same voices and the same names, and we enjoy the new ones, but we really love that the people that keep, the recidivists, the people keep coming over and over again. So that does bring us to the end of our time. If you've missed any part of this conference, as I just said, it has been recorded, and it's going to be available through our MS Focus Facebook and our YouTube channels. Give it a week or so, and Kamani will have it up there. A reply to your registration email for information on how to access the recordings or to sign up for our newsletter to learn about any of our upcoming events. Our next teleconference will be this coming Friday, July 12th at 3:00 p.m. Eastern. Sherry Binns, who's our patient healthcare liaison and also an MS certified nurse, will be presenting the same as Dr. Thrower, a Q&A, but this time it's Ask the MS Nurse. So you'll bring your questions regarding symptom management, and she's also fabulous at that. So as you leave the conference today, it's very important because we have a survey that appears on your screen. And we really, truly want to know what works for you, what you want to hear, and what you thought about the program that we just gave to you. So please take the minute, it's very short, to fill that out so we have a better understanding of what's meaningful to you, because that's what's important to us. So our sincere thanks to all of our attendees for your participation, and especially to Dr. Thrower for once again astounding us with his vast knowledge and his willingness to answer everyone's questions. Have a wonderful evening, everyone, and we hope to see you again. Bye, everyone.